Hey, hey, guess who? It's Beth Wright providing you a podcast for your last unit 236. Yay! And we're going to first talk about the drugs for coagulation disorders, chapter 7. And when you look at that word coagulation, what does that mean? It means clotting. So we're dealing with blood with drugs that deal with clotting disorders, okay? And we should say anticoagulants. Now we're going to have talk about anticoagulants, and we're also going to talk about antidotes for those anticoagulants as well. So you know that when we're talking about clots, we're talking about thrombus and embolus, and we know that those can kill. And we also know that medicines given to treat these can also kill. If you haven't read or heard about the story with Dennis Quaid, the actor, and his twins, they were given, the twins were given right after they were born. They were given heparin, and the nurses gave way too much heparin, and it nearly killed them. That was a very scary moment for them. So hospitals are being held accountable if patients develop thrombus while they're in the hospital, and also they're being held accountable if we overdose on coagulants. So there's core measures that, first of all, from Medicare that have been developed for the development of deep vein thrombosis or embolus development, that patients with certain criteria should be on some kind of prophylactic. There's also the Joint Commission rules that talk about high alert medications as well as lab work that must be reviewed for any kind of coagulants. So, we got it coming from both ends here. We got to prevent the thrombosis and the embolus, and we also have to give safe care when we're giving anticoagulants to take care of DVTs or any kind of clotting disorder. So very, very important. We've got to be sure we give very safe care when these medicines are involved. Okay, let's talk about hemostasis a little bit. It's basically a process. Hemostasis is a process where, it saves our life, keeping our vascular system intact. It's all a complex process. We have the plasminogen. The blood clot binds to fibrin to form a clot when we have some kind of an injury, and the blood flow stops to that area because of that clot. And then we get the repair going on, and after all of that is done, the repair is happening and that kind of thing, then plasminogen is converted to plasmin or fibrinolysin that helps break down that clot that initially first saved the day. So, just kind of keeping it simple that way. And we know that, we have prevention or stoppage of blood loss from injured vessels because of that clot formation. And it involves vasoconstriction and the formation of that clot or the platelet plug. And of course, lots of activities with the clotting factors are going on. And then, of course, the repair of that damaged vessel happens. Now, the thrombogenesis. Now, thrombo is thrombocytes. Okay, that's what we're talking about. Thrombocytes are your platelets. And again, we have that normal body defense that comes to play anytime we have some kind of injury or inflammatory response, that kind of thing happening. And this can occur either in the venous area or the arterial area. And of course, if the thrombus stays put, we refer to it as a thrombus. If it starts moving, we refer to it as an embolism. And, again, that's just the formation of a blood clot, the thrombogenesis. And it is our normal body defense to prevent us from bleeding out. And it's life-saving in many instances, if someone's hemorrhaging or, that kind of thing. But as we know, if a blood clot forms, then and it obstructs blood flow to that tissue, then we can have ischemia that occurs and some, really damaging events that can occur. Atherosclerosis is where we have hemorrhages, kind of a continuous injury to the vessels, okay? We got hemorrhages, we got ulcerations, and then we got scar tissue that develops over time, of course. And they also refer to that as hardening of the arteries. And of course, that can affect any organ or tissue. We think about the heart. If the thrombus forms from atherosclerosis in the heart, then we know that that can cause an MI. In the brain, if a thrombus forms, then we can have a stroke. And then in the legs, it can precipitate into a deep vein thrombosis, or DVT for what we call it. And again, can occur anywhere in the body. So just kind of be thinking about that. Again, it can happen in the arteries and the veins, and in arterial thrombosis, where we're talking about the atherosclerotic plaque, hypertension, and it's going to cause that turbulent blood flow, and again, damage to that endothelium, to that tissue in there, and it activates the platelets to help come to the rescue, to form a clot around that, and of course that continues to narrow the blood flow within that area, and then eventually causing an obstruction. And that's when we talk about ischemia, where there is a decrease of blood flow and oxygenation, and then an infarction is where it's completely shut down, the blood flow and oxygen to a certain specific area. Now, venous thrombosis is referred, we can associate that with the venous stasis. So if we don't have, if we have venous stasis, that means the blood is staying there, okay, and it's not flowing like it should. And so when that happens, we can get a formation of a thrombus occurring, and that's where we see a DVT and an embolization that can occur. Also, peripheral vascular disease can occur with this as well. So here are our exemplars, our heparin and low molecular heparin, and warfarin is our anticoagulants that we're going to be talking about. The clopidogrel is another type of medicine that can help with this, as well as aspirin. Then we're going to talk about thrombolytics, and then we're going to talk about protamine sulfate and vitamin K, which are your antidotes. Okay, so antithrombotics and antithromboembolics are medications we refer to as anticoagulants, antiplatelets, and thrombolytics. You can see the thrombolytics, they dissolve the thrombus, and they limit tissue damage in any thromboembolic disorder. Antiplatelets are used to prevent arterial thrombosis, and then anticoagulants are used to help with the thrombotic disorders such as DVTs or, different things like that. Now, the anticoagulants prevent formation of new clots, but they do not dissolve clots that have already formed. So that's important to keep in mind. Antiplatelet drugs, again, are used to prevent, and thrombolytics dissolve the thrombus right on the spot. So let's talk more about anticoagulants. So we give to prevent new clots, and we do not give to dissolve formed clots, improve blood flow in the tissue around the clot, or prevent ischemic damage beyond the clot. That's not what that's used for. It's used to prevent new clot formation. And, the conditions that you might see it used: thrombophlebitis, DVTs, or PEs, pulmonary embolisms. The main adverse effect for all of these medicines is going to be bleeding. So we got to watch the patient about that. We got to assess the patient for any kind of bleeding, bruising, hematomas, petechiae, looking at their stools and sputum and anything like that, urine, anything coming out of their body. We got to look at to make sure there are no signs of bleeding. And sometimes that might mean to do an occult blood, like on the stool, or you can do that also on gastric secretions. We got to definitely monitor that carefully. So with the heparin, that's what we're going to talk about first, was regulated by the activated partial thromboplastin time, or the APTT. Okay, so that's, when we are giving heparin, we got to monitor the APTT results, and it is, done. We draw that 1 hour before dosing is done, okay, or the lab will draw it. I'll wait for you to remember that the APTT goes along with heparin. Look at the end of that. Okay, it's got TT. If you did it like a lowercase t, what would the end of that look like? It would look like a heparin. It would look like an H if you did the TTs like a lowercase. So the TT goes with the heparin, okay? Now, warfarin is regulated by the PT, the prothrombin time, and the INR. And that's what you're typically going to see there with that. And the lab work is done daily until it's therapeutic, and then every 2 to 4 weeks while they're on that anticoagulation, unless there is a dose adjusted. Okay, so let's go in depth a little bit more about heparin. It inhibits the action and formation of several clotting factors, and the interference with this clotting cascade causes a prolonged partial thromboplastin time and increased bleeding time. Heparin cannot be given orally. It's only sub-Q or IV. The reason is it can, if you give it IM, it would cause a big old hematoma. So we don't want that. It acts rapidly, so sometimes you'll see patients are started on heparin, and then they're also started on an oral PO anticoagulant such as warfarin. There's a normal range for the APTT, a therapeutic range for when a patient is receiving heparin, and a range that is too prolonged or therefore dangerous. So heparin has a short life, and it may be stopped for a short period of time to adjust that APTT if the APTT is too long. Therapeutic range is 1.5 to 2.5 times the control or the normal value of 25 to 35, I think is what I've got in your notes there. And the other thing about heparin, it should only be ordered in units, and it should be spelled out units, because some people write the letter U uh, that looks like cc's, and that can be very dangerous. So it should be, if you don't see your order in units, you need to call the prescriber and ask them what they want, okay? Also, an infusion pump must be used with heparin drips. Um, Now, intermittent IV injections of heparin may also be given, and of course, sub-Q injections may be given as well. Remember, you're going to have to monitor your patient, monitor the labs for sure when giving this medication because of the adverse effect of bleeding. So, after a thrombus has developed, heparin can inhibit additional coagulation, so that's a good thing. It's also used prophylactically to prevent DVTs and PEs in patients with certain disorders, surgery patients, or people at risk for PEs, any kind of gynecological surgeries, abdominal surgeries. Those are the surgeries that are hard for people to get up because of the pain and stuff. So you'll see heparin given for that, and people who are on prolonged bed rest. Again, prior to giving heparin, we've got to be reviewing those labs, including the APTT and the CBC and the platelet count. Why do we want to view the CBC and the platelet count? Okay, would that give us some idea that a patient is bleeding, or what their red blood cells are, what their platelets are, if the platelets are too low or too high? I mean, we definitely got to look at these labs before we give this because we're responsible. Now, heparin is also used for the disseminated intravascular coagulation, or DIC. And that's, where the body is, the whole clotting thing is messed up bad. Patient is clotting at the same time that they're bleeding. And so it's all, all messed up. The clotting factors are all messed up. And so the goal of the heparin with DIC is to prevent the blood clotting long enough for clotting factors to be replenished and then to help control the hemorrhage. Okay, again, heparin given for the prevention of DVTs, and also we will use the SCDs, or the pneumatic compression devices, and other measures, getting the patient up, walking, and hydration is important as well in this. So all those other measures that we do should be instituted as well. If the platelet counts falls below 10,000 or 100,000, then it's necessary to discontinue the heparin. So adverse effects we know is hemorrhage, and also heparin-induced thrombocytopenia. So what is it we got to look at? We got to look at the platelet count. We got to hopefully had one before we started the heparin, and we got to be monitoring that. And we're going to be looking for signs of bleeding, such as, subcutaneous bleeding, like the petechia or bruising, blood in the stool, gums, bleeding gums. The gums are real fragile and potential to bleed as well. And we've got to provide the patient safety as well. We've got to think about things like that with the safety issues going on. Our contraindications are going to be GI ulcers, any kind of intracranial bleeding, aneurysm, severe hypertension, any kind of hemophilia or other bleeding disorders, peptic ulcers, ulcerative colitis, and anybody with a threatened abortion. We'll definitely want to be concerned about that, and also patients who are frequent users of alcohol, just because of the gastric issues that they may have. Now, patients who are going to surgery, usually the surgeon will have some kind of specific order for when to start heparin post-operatively, and so they may say, heparin 5,000 units sub-Q every 8 hours, start 6 hours after surgery or after the epidural catheter is removed. So, to be really specific. We also need to know about if the patient's been taking any kind of herbs, because they can definitely induce bleeding or prolong coagulation. So there's a lot of herbs that are drug-drug interactions. Um, we got to remember a thorough history from the patient. And so administering the medicine, we're going to look at that APTT to measure that, and our range should be 25 to 35 seconds. We want to maintain it at 1.5 to 2.5 times the control of 25 to 35 seconds. So we need a baseline APTT prior to starting the first dose of heparin. And the antidote for heparin is the protamine sulfate. So that's got to be nearby in case the patient does get too much going. Now, you may see heparin also used as a flush for central lines. And, there's been evidence-based studies done out there proving that normal saline is as effective and much cheaper with less side effects to it. However, you may see for PICC lines or central lines that some hospitals still use the heparin to flush. Now, you need to be very careful about the dose on that, because it is going to be much smaller than what you would give for prophylactic DVT or for DVT care or for PE. So got to be sure you got the right dose for sure, okay? Don't forget about the protamine sulfate being your antagonist here for heparin, and that is what we used for the antidote, okay? Now, what would give you some reason to believe a patient has been, overdosed too much on the heparin? If you don't have time to get a blood draw, and sometimes you won't, you're going to see hemorrhagic shock. So you're going to see low blood pressure, rapid weak pulse, pale, cold, and clammy. And so you need to call for help if you're seeing any kind of patient in that situation. Don't leave the patient because they're going to feel like they're dying, and they literally are dying. And so you're going to call for help, get some help in there ASAP, get the doc on the horn, and stay with that patient and be continuing your assessment. Now, low molecular heparins are also available. That's Lovenox, enoxaparin, dalteparin, or Fragmin. So there's, several that are out there that are used, and this is, again, for the prevention and management of PEs and thromboembolisms or ischemic complications or MIs. It is not interchangeable with heparin. Now, it is, excuse me, they have a limited action against thrombin, so lab testing isn't necessary like it is with heparin. These have a longer duration of action, so they have more predictable results. These drugs cause bleeding issues just like heparin does, so that's our main thing. Overdose of these drugs are treated with protamine sulfate. We only give these sub-Q, and sometimes they have special syringes that they come in. So be sure to read the insert that comes in the packaging. A lot of the syringes have an air bubble in it, and we don't purge the air bubble with this. They do not want you to do that. And of course, heparin is just like heparin. These are given sub-Q, and typically we give them in the abdomen. Now, vitamin K antagonist is our warfarin or warfarin. The trade name, of course, is Coumadin, and it interferes with vitamin K dependent clotting factors. Therefore, an increased amount of vitamin K will interfere with the ability of warfarin to be effective, prolong the PT time or the INR time. So we need to think about, this is where we teach the patient certain foods that are high in vitamin K. They need to keep those foods consistent in their diet, and they don't need to overdo it. Like, don't go on a rabbit diet now, thinking that that's going to help your DVT or whatever. We need to teach them to take a consistent amount of the foods with their intake, so that the warfarin dose is not affected, or their labs are not affected. So we definitely need to do the teaching there. It's prescribed for prevention of thrombus development in patients with AFib, atrial fibrillation, or prosthetic valves that are being placed in the heart, or venous thrombosis. So that's where you typically see these. The action of the medicine takes hours up to a day. So this is only the onset and not a therapeutic level. So you may see patients, again, they're on the IV heparin and on the warfarin, or they may be also taking a low molecular weight heparin along with the warfarin until that PT or INR are within that therapeutic range. Overdose of warfarin is treated by holding the medication if it's mild, or given vitamin K. So vitamin K is your antidote for this. Hopefully a blood transfusion won't have to be administered because of so much blood loss, hopefully. We avoid vitamin K if possible due to the long-term effects on the anticoagulants. So, of course, the healthcare provider is going to be the one that decides that. So, again, we use it for prevention of DVTs and pulmonary embolisms. And, of course, patients may be on it after an MI, also for AFib and for prosthetic heart valves. We use this in caution with patients with hepatic impairment because it's eliminated by the liver. And, of course, our adverse effects is bleeding, hemorrhage. We've got to watch about that. Also, nausea, vomiting, abdominal pain, alopecia, urticaria, dizziness, and joint pain. Our contraindications: GI ulcers, intracranial bleed. So it's very similar to what was in your heparin contraindications. Okay, must do a daily PT-INR until it's stable, and a therapeutic range is approximately 1.5 times the control, or 18 seconds, or the INR between 2 to 3. So if the PT is greater than the control, that warrants a call to the physician, of course. So the PT measures time it takes for blood to clot, and if have increase in time, that means the patient's at risk for bleeding, means the blood is too thin. So we've got to assess the patient for any kind of bleeding, and we're going to have those same precautions as we do with someone on taking heparin. We got to assess for therapeutic effects, and we got to assess for those adverse effects. So any kind of bleeding, we're going to be watching, just like we talked about with the heparin. Teach. We got to teach the patient about the drug. It's crucial. Be sure to teach about diet and signs and symptoms to watch from, and the requirement of following up. They've got to get the lab work done to see how they're doing, to see if they're in that therapeutic range. It's going to be very important. And also we can tell the patient it's a good idea to get a medic alert bracelet, so that, folks, in case they're in an accident or something, folks will know. Okay, thrombolytic agents are given to dissolve the thrombus, and you might see these listed as fibrinolytics as well. What I like to call these drugs is human Drano, because that's what they do. They put it in there and they clean the drain out, or the pipes out. So these agents break down the fibrin clots. Okay, all clots in the person's body are dissolved when these agents are used. So the healthcare provider, with the help of the nurses, will review the patient's history carefully to see about risks of bleeding before these agents are ordered, and there are specific criteria to give these. Now, the management use of this is management of acute severe thromboembolic disease, such as an MI, a pulmonary embolism. Now, you don't see these done so much anymore, this medicine used so much anymore, except in a stroke situation. The MI use of it, what we do with patients these days is they go to a cardiac catheterization and have that to open up that vessel instead of thrombolytic agents. And the reason is there's, that's much more effective. Believe it or not, a cardiac catheterization has less side effects than these medicines, because these medicines can literally cause somebody to bleed to death. Okay? But when they are used, they're meant to reestablish blood flow as quickly as possible and prevent and limit tissue damage. So, for strokes, they're given within the first 3 hours after symptoms of a stroke onset, if there is proof that the person is not having a hemorrhagic stroke. So, if the person wakes up with symptoms, then the last time they were seen without symptoms is when the window for giving the fibrinolytics agent starts. So to prevent bleeding in the brain, the patient will have like a CT scan as well, and to make sure that there isn't bleeding going on, and to prevent further bleeding going on, we will start them. Or we will make sure that they don't receive any kind of anticoagulant and antiplatelet drug for 24 or 48 hours after they receive a thrombolytic. The window is longer for acute MIs, is up to 6 hours or longer in some universities. The half-life of these medicines is really short. So in myocardial infarctions, the infusion is followed with heparin, aspirin, or Plavix to prevent reocclusion of the blood vessel. Another one of these medicines, the urokinase, you may see also used to help clear central lines or porticas, things like that, but at a much, much, much lesser dose. So thrombolytic therapy is performed only by folks who are trained to do so, and cardiac monitoring has to be on the patient at all times. And then there's the baseline labs that are done to see, about pre-administration there, see where we're at. And of course, factors that have to be included are meeting the criteria of this, so that we don't give this medicine to someone who is at risk for bleeding. Alteplase is one of the medicines. This is a tissue plasma activator, also known as TPA. And again, it reminds me of the human Drano, because it disintegrates the clot. The same time frame window period there for this medicine to be used is the same as the thrombolytics. And same precautions, all of that will be the same for these medicines. So got to do a thorough history on the patients, just as with the thrombolytics. It's given to patients for MI, ischemic strokes, or pulmonary embolisms. and it's not recommended for individuals over the age of 80. Of course, the big adverse effects is bleeding. Now, one of the things when you see these medicines given, they will start one line to give the medicine in and another line to draw blood work in, because again, the patient is at risk for bleeding. So anytime, we're taking blood from the patient and we're having to stick them again, this is another hole for the patient to bleed from. So we want to avoid any kind of additional sticks if at all possible. We're not going to give antiplatelets or anticoagulant drugs while this is being administered. If in an overdose, the aminocarpyric acids serve as an antidote for these medicines, which is your protamine sulfate. Also, EKG has to be going when we're given this, and is the coolest thing. I've seen this medicine actually work with an acute MI, and you see an elevated ST segment when the patient first comes in. They give TPA, and you can literally see that ST segment coming down. It's the coolest thing ever, and reperfusion beginning to take place. Now, when the heart gets reperfused, expect dysrhythmias that can occur, and so dysrhythmia medicines have to be available. Limit IM injections or venipunctures, again, because of the bleeding issue. We got to check those labs before we give this medication. And with MIs, again, expect the dysrhythmias and that we will be giving anti-dysrhythmias if they occur. Okay, so aminocaprotic acid are the medications that are used for antidotes. Protamine sulfate is your heparin, and vitamin K is given for warfarin. So we have to, have those readily available. So we have to also, understand that it's going to stop the bleeding. So we got to adverse effects that are going to happen because of stopping the bleeding too. We can again go back into our clotting mode, and that may not be good. Okay, our antiplatelets prevent one or more steps in that thrombotic activity, and we can either work with this as far as inhibiting platelet activation, adhesions, aggregation, or the clumping of the platelets together, or the coagulant activity. And of course, adverse effects are going to depend on which antiplatelet medicine is used. So aspirin, you had this medicine a long time ago in your first semester, I think, of pharmacology, or maybe your second. But aspirin is also referred to as salicylates. And you can give this medication usually at a lower dose for antiplatelet effects after patients have had an MI. And it works really fast to help that platelet aggregation. There is no antidote for aspirin, by the way. Okay, and then we have our clopidogrel, or Plavix is your trade name. And these, the onset of this is within an hour, and it lasts up to 8 hours. So the delayed onset of action is a shortcoming of it. It does have irreversible inhibitory effects on the platelets and significant individual variability in the platelet response that occurs. If a patient is experiencing an MI, they may be given a higher dose initially, and may need a higher dose if they're plans to go to have open heart surgery. But they may have to wait several days for the surgery until the large load dose is metabolized because of fear of bleeding. There is no antagonist for this medication. The patients need to be taught about the drug and that it increases bleeding. And you may see healthcare providers prescribe both aspirin and Plavix together. Okay, and so I'm so sorry about the top of that slide. I do not know what happened. But, anticoagulants are given to people who have had or at risk for MI, stroke, or other problems with blood clots. And for DVTs, patient will normally be given heparin injections followed by PO warfarin for long-term therapy. And again, these help prevent blood clots from getting larger and traveling to the lungs and reoccurring later. And of course, we have an increased risk for bleeding, so we got to take safety precautions. We teach them about not using a razor, to use electric razor, watch about toothbrushes, use soft toothbrushes. I mean, all the things that go along with bleeding, we want to teach them about and teach them to observe and notice if there is any bleeding and to notify their provider if that does in fact happen. Reducing blood clot formation by preventing cardiovascular disease by eating a heart healthy diet is going to be important as well. And to prevent DVTs, refrain from wearing any kind of tight clothing. The knee highs that come up and they cut off the circulation. We need to avoid crossing our legs at the knees or anywhere for that matter, or prolonged sitting or standing. And for automobile trips, stop and walk every 1 to 2 hours. They need to be sure to take their medications as prescribed and to be following up with their blood work. They need to stop smoking and avoid walking barefoot, contact sports, anything like that. They need to inform their dentist about taking anticoagulants and, of course, to report any signs of bleeding and to switch injection sites for anything that the patient is taught to give. We've got the low molecular weight heparin listed there, but they need to rotate those sites to, decrease any injury to the site of injection there. Okay, that concludes this podcast.